Hello, hello.
It's good to be Nihaal for a change.
हेलो आइगन शुरू करें आप रेडी है क्या आपका ये पहला है
I'm ready.
ओके ऑलराइट
Just keep an eye out for that doctor if she tries to join, okay?
ऑलराइट Rajkumar make Dr. Manka the panelist and the
I
co-host.
am a panelist at the moment, and I also have
Okay,
Astik who's joining me because it's a Gosh case.
done. Okay,
Okay, I am very happy to share the screen for the moment.
okay, go ahead, please.
Do we have Vivek, etc. in the room?
Let me just check. Dr. Ramesh is there.
Oh, great. Okay, perfect. Hi, Dr. Ramesh. This is a case that originated at Sheffield Children's Hospital in the north of England and was brought to our infectious diseases meeting, which is a special interest group meeting, as of yesterday. And I thought it might be a useful discussion in this forum because you guys have the largest critical mass of these patients. And in terms of background, this child is now 3 years of age, but at first presentation was around just under 2. And the first episode was at 9 months of age. In fact, where in a car seat having a nap, she woke up and had a weak right arm, flaccid on one side, attended the ER and it resolved by 4 hours, did not have a scan, and then was followed up by general pediatricians with no concerns. The second episode, which becomes relevant to this CT scan, is the day preceding the CT scan. She fell off the sofa, bumps her head on a carpeted floor, develops right-sided facial arm and leg weakness, and then CT was carried out 24 hours later. Also develops chicken pox 2 days after presentation. Her sibling, her brother had chicken pox. And then I'm going to show you the CT scan at this point in time. There are further episodes that become relevant. So we are now on 31st of December 2024, and the kid was born on the 19th of February. So I'll let you do the maths in terms of how old she is, but quite young. And on the CT scan, what I observed was these little areas within the ganglionic structures, which you already see as low density, perhaps lower density on the right. And then on this side, also low density, but not as much.
Dr.
And
Manka
the
आपका
other
screen नहीं दिख रहा है. Please tell me.
which screen are you able to see?
I'm not able to see any screen.
I'm sharing a screen.
Okay,
Everyone's
CT. Yeah, got it. Okay.
Yeah. Okay. I'm sharing it back.
Yeah.
Okay.
Got it. Thanks.
All right. Okay. So here you have to focus your attention on some of these hyperdense foci, which I will show you on the coronal as well, which turns out to be the fact that there is some calcification in the lenticulostriate vessels. In addition to that, we also picked up calcification in one of the cortical veins higher out there in the superior frontal region on the left side. And the episode here was developing right-sided facial arm and leg weakness. That kind of 24 hours later CT scan. And then this is a coronal, always a better view to kind of see what are these calcific areas, and they do turn out to be what look like lenticulostriate arteries. So at this point in time, the local hospital had not called the ganglionic infarcts, and that's it. The CT was done. The possibility of vasculopathy was raised locally, and the child was essentially sent home with some other tests done. They have a second episode after that, a third episode, in fact. They have an MRI scan before that. This is like just a routine follow-up scan. And you must be wondering as to why the lag between different modalities, but this is New England for you. So this is 19th of January, and that is more than 2 weeks after that CT scan. So we do have these two lesions, and you will still wonder whether they are of different ages. This looks more kind of already lost volume in the lentiform nuclear complex. This is the left side. And this is a larger lesion at this point as well, all mature with no diffusion changes. And a contrast was also given on this particular occasion, which becomes relevant, and I can show you the SWI and all in a moment. But on the contrast, what was picked up was called leptomeningeal enhancement, again affiliated to that cortical vein which we had picked up as a calcified structure. Now, looking at this, and it's only one kind of contrast sequence that has been done in two planes, the radiologists hopefully will agree that we can see what has been called as enhancement, but you wonder if it is to do with the vessel in itself, or is it something kind of proximally related to that. Whether it is truly a leptomeningeal process or not needs to be determined. But if you look at that area, then you will see it's kind of peel, subpeel, kind of linear, curvilinear enhancement that was picked up. Okay. So once again, on the axial, slightly better shown is this area here. And then what happens is that was called leptomeningeal enhancement. They've got bilateral basal ganglia infarcts. There have been no clinical events, but they have a third episode in March of 2025, so 2 months after this MRI scan. And on the third episode, there are no new brain lesions to call as such. You can see the T2 signal of those mature gliotic patches are still the same. This time, more acute imaging was undertaken, CT followed by MR. Nothing really acute to call on that scan. This was not enhanced. Luckily, we don't need to enhance everything. And I'm happy to walk you through MRA, MRV, but it doesn't contribute. And the CT scan, essentially, once again, which preceded the MRI scan, shows you a little more obviously these lenticulostriate calcifications, but also this cortical calcification out there, which goes around the surface of the brain. And I wonder what we are picking up as enhancement basically is some kind of a vascular anomaly there. A thought before we call it leptomeningeal enhancement and go down a different pathway. So I will park there. I'm happy to answer questions about CSF, etc., because the neurologist, who I don't think is in the audience yet, had sent us slides. But at the moment, my questions are quite simple. If we are calling this mineralizing angiopathy, which is what we have called it, with lenticulostriate calcification and these very kind of minor, low-level traumatic episodes causing infarcts, which sometimes have gone even unmissed, the question is, have any of you seen a cortical calcification in association with that as well? Or is it just a secondary finding of some description? The reason Sheffield brought this case to us was whether this was kind of related to the varicella story in any way. And I think we can confidently say that this is all not post-varicella in its own way. Whilst you guys are trying to help us with that, I will show you all the investigations, but I'll stop sharing the imaging. There's nothing more to that. So really open to your views on this case. Let me just bring up another presentation.
Dr. Ramesh here. So after the third episode, there is no diffusion abnormalities after the third, that is in March 25.
That is correct.
How long this lasted episode of hemi weakness, the last one? Was it
so recurrence of right-sided weakness. This is the third episode. No head injury or fall. Focal clonic jerking. Weakness takes over 3 days to resolve fully. And then the MR, which is done.
So this followed a seizure, is it? This weakness followed seizure?
Correct. Yeah.
Okay. So a question about the calcification in the subcortical region. We did have at least 3 cases who had subcortical calcifications also. That was not included in the initial series that we published. One of them had hypoparathyroidism. The other 2 did not have any obvious calcium metabolic abnormalities. But they didn't have so many strokes. All of them had just 1 stroke and no recurrence. Even that the child with hypoparathyroidism did not have a recurrence, but had subcortical calcifications.
That's very useful to know. Are you planning to publish it?
We do have the details.
we'll be happy to add this case. I'm sure Sheffield would be keen to put this out because there's nothing in the literature that we could find in this respect. And also the question to radiologists particularly is this enhancement that, this is the 5th of March. This is just before the 3rd episode happens. This was a routine follow-up. This enhancement persists in that area. Are we just picking up actual leptomeningeal process, or is it an anomalous vein or something that is just enhancing away? Some chat messages, yeah. It looked like a very vascular structure, right, which has been called as leptomeningeal enhancement. But did you all have any contrast enhancement with these vessels? Because I know with the Indian cohort, having spoken to Lokesh, you guys have done a pretty comprehensive genetic workup on these cases. You've not found anything. Inflammatory workup. Have you gone as far as screening for things like interferonopathies, for instance?
No, we didn't screen for interferonopathies. The genetic evaluation we did for initial, I think 8 or 9 patients in the series. As we were not getting anything, the coagulation workup and genetic workup. Subsequently, we stopped doing genetics, except I think we preserved the samples for most of these patients. In case some research fund comes along, maybe we can do genetics and all. We haven't done in all. But whoever underwent genetic testing, we didn't get anything.
So with your permission, I'm going to connect you with Yannick Crow, who has the world's largest experience in interferonopathies. You all might know him anyways.
Yeah.
And I think if these samples could be shared, because he runs a lab particularly looking for interferon signatures. A discussion point that came up yesterday was to send the case for as referral to him to see if interferons could be excluded from the midst, because there are calcifications and we really haven't found anything else. But it's a long shot, but there is nothing else. So you think this feature ties up well with the lenticulostriate vasculopathy itself?
We had it in 2 cases other than hypoparathyroidism, but we don't know how it relates to the lenticulostriate vessels. A common pathological mechanism maybe.
Sure. And the 2 cases that had hyperparathyroidism, did you say?
No. Out of 3, 1 had hypoparathyroidism, 2 did not have any abnormalities. The calcium pH profile was all normal. Only 1 had abnormal.
Okay, and I presume they were not contrasted with MR and all that to see if this phenomenon was happening there.
No, we didn't do MR in many of them.
Okay, Eugen has his hand up.
Thank you. As you know, I'm not a radiologist. My experience is, of course, much less than you have in India. I've seen a few cases in Switzerland and in Armenia. And of course, in retrospect, it's a pity that this child had no CT during the first episode at 8 months. I know this condition can start at that age. And my hypothesis would be that this is just, all these episodes are related to that calcified lentiform vessels, and whether the subcortical finding has anything to do, I don't know. I don't think it's, for me, that relevant. And the later question about the varicella, this is unlikely caused by varicella, but it may be a trigger. But for me, this is kind of an ongoing, repeatedly episodes bilateral, which is not uncommon in that calcified lenticulostriate vessels.
Thank you very much, Eugen. If nobody has any more points to make, Shaima, you had I think you probably missed the CT. In that area, they also have a calcified vessel. So my question really was whether this phenomenon has been observed with lenticulostriate vasculopathy in itself. So, Nihaal, you have anything to add from radiology?
No, I haven't seen. I think Astik and Dr. Vivek have raised their hands.
Astik's hand is up. Okay.
Yeah.
And Vivek's hand is up as well. Very important.
So my experience is not as much as in Hyderabad with what Ramesh and Lokesh have. The patients which we have seen over the last few years, it's highly unusual to have more than 2 events. I've never seen more than 2 events. At the most 2 events. 85% of them had just 1 event. So 3 events is really odd. And in the 3rd event, but maybe people have seen, to have a clonic seizure. So I haven't seen seizure in these events, maybe day 4 dystonia of the weak arm, but not seizures. So that's one. So, and this lesion, cortical, subcortical based lesion should be further explored with a catheter angio, because this history is unusual for mineralizing vasculopathy where, well, and if you have bilateral lesions, the patients I've had, so I've had a patient, I have had few patients, they will have a right side stroke, they have a left side lesion, and now they have few weeks later, or maybe a month later, the opposite side involved, they really worsen. So if they have a second stroke and both basal ganglia are involved, they develop pseudobulbar palsy, they go on to NG feeds, and it's a difficult task to bring them out. So these two bilateral basal ganglia are not matching with the child's clinical status. As for interferonopathies, so we have been doing interferon score in SSP patients, and it's coming high. So the message is don't give interferon in SSP. So this we are doing with PGI, Dr. Amit Rawat. So in fact, I had emailed Yannick Crow because I knew him from Leeds 20 years back. And he actually directed me to Amit Rawat in PGI because they took his help for interferon score. So it's a very good thought that in these patients, we should do an interferon score, and that can be done in-house in India.
Thank you so much.
That's an interesting observation on SSP. This is Rajesh. We had done that original study, and surprisingly, in fact, in our cohort, we had about 32 patients or so from India. About 4 or 5 patients actually worsened after giving the interferon. So maybe, and then I've sort of, now the interferon is not even available, the one we used to give. That's an interesting observation. Maybe.
Yeah, so we have done it in around 9 patients now. So I have to assimilate the data. Majority we have high score. High scores.
I see.
Okay. Astik, did you have anything to add?
No, I just wanted to ask Dr. Ramesh, interesting that you also had 3 cases. I think you mentioned subcortical. Yeah, if at all possible, if we could see some of those images, because I think in this case it is more, rather than subcortical, it is overlying the convexity and is clearly associated with a vessel. So it might be different from your cases, but yeah, it will be useful to see whether the pattern is similar or slightly different.
Sure, definitely. I'll try to retrieve them. And I also agree with Vivek that the radioclinical correlation is not so great in this patient. We saw only one patient who had a third stroke, that too after a long gap at around 6 years of age, which is a little unusual for most of them. Just one stroke. And if somebody has bilateral stroke, they have significant disability going forward. So that's our observation.
Thank you so much. I'm going to summarize so Nihaal's meeting can move on. So in summary, we are recommending as a group that the child should have a catheter angiogram. I think that's already been planned in Sheffield, particularly to explore what's happening in the cortical, subcortical region on the left side. The interferon signature is a good idea, and hopefully you all will be able to do interferon signatures for your patients as well to see if something comes up, if you can do it in-house, which will also provide adequate material for a future publication in this space because so much is not known. The third thing is it's clinically very unusual to have 3 episodes or more of these kinds of episodes, and particularly tonic-clonic seizures in that context of just mineralizing angiopathy-related strokes. Have I captured that correctly? Vivek, in terms of management, would you recommend anything else for me to pass it on to Sheffield?
Yeah, that's yeah. You summarized it so well. We all give aspirin. We don't even know if it works or not.
Are you happy with the dose?
I won't go beyond 3 per kg per day now because we really don't know if it helps. We really don't know because we have given it for 6 months and then we stop it because the angio is, the angio of that area is normal. So, but everybody gives it. So but my colleague, Dr. Mahesh Kamte, he has not given it for quite a few of his patients. He did a study and they didn't have a recurrence.
Yeah, I also agree with.
Sorry, were these patients iron deficient?
That's their profile. I can ask for iron deficiency. I'm aware of the link between iron deficiency and this, but I can ask for iron deficiency status.
Because majority of our patients are iron deficients.
Yeah, I've heard that.
70% of them, yeah.
Okay, so atypical features for mineralizing angiopathy in itself. And you're happy with the aspirin dose. They're getting 1 milligram at the moment per kilogram body weight. You'll not go beyond 3 for that. And then I agree. There's a comment here in the chat from somebody called iPhone. Looks like an AI pilot.
I think that's Dr. Shaw.
Dr. Shroff? Okay. Yeah, DSA may not actually.
Shayan, sorry.
Shayan the Great. I quite trust Shayan's views on things. He's right. I think the pretest probability of finding something on a catheter angiogram here is very low, but it has to be done for completion, isn't it? And I'll come back and feed back to you all. They're a bit stuck with what goes on here. Okay, thank you very much.
Okay, thank you. All right. Yeah, with that case, we'll move on to our next case from PD India Mumbai. Basit is there. Basit?
Yes,
Please
sir.
go ahead with the
Yes. So we have this 3 months old male child, third birth order, born out of non-consanguineous marriage. At around 2 months of age, he had excessive irritability, crying episodes, incessant crying, and became lethargic. He had multiple episodes of vomiting, and he was admitted to a hospital. And during the hospital stay, it was mentioned that he had multiple episodes of seizures, as he was intubated and kept on mechanical ventilation for 20 days. During the hospital stay, it is mentioned that he had hypertension during the hospital, but after that he was discharged, and since then he has had no seizures. So currently on presentation, he was delayed in his milestones. They were at around 3.5 months. He had no neck holding, no fixing and following, and his on examination, he had his head circumference of 41 centimeters, and he had brisk deep tendon reflexes. So basically, currently he was developmentally delayed at the 3.5 months of age.
All right. So with that background, I think the child had multiple scans. We'll start
Yes.
So this was the first scan, non-contrast CT done
this
on.
Was the emergency study that was in that time, at the time of admission only.
Okay. Yeah. So as you can appreciate, there's diffuse edematous changes predominantly in the peripheral regions of the brain. Supratentorally, some areas of the possibly internal capsule involved, demonstrating edematous changes. Also, the infratemporal structure, the cerebellum also has edema out there. Let's see if there's any hemorrhage. Okay, intraparenchymal cannot appreciate any hemorrhage. Extraaxial, very difficult to say on these, possibly along these posterior parts in the parietal region, but yeah. The predominant changes are diffuse cerebral edema, cerebellar edema. The cerebral edema is more predominant in the peripheral regions, the subcortical deep white matter and the cortical regions. I don't have stat sequences or kernels for any obvious herniations, especially the posterior fossa, but there's no significant midline shift at this point of time. Yeah, we have interval MRI. Anything in between, Asit?
No, sir. This was MRI done 2 days after the CT scan. Yeah.
All right. So MRI again corresponds correlates with the CT scan on the diffusion sequences. You can appreciate again the diffuse edema again involving the subcortical cortical regions, central white matter, and also the posterior fossa structures, especially the cerebellum on both sides. And on the T2 sequences again corresponding edematous changes, they are diffusely involving the supratemporal infratemporal structures. There's possibly some laminar necrosis out there. Maybe T1 weighted sequences will be better appreciated, especially in the cortical regions, in the bilateral, parietal, and occipital regions. SWA sequences could not appreciate any areas of interparenchymal hemorrhage, but if you look at the last two slides out here, there are some extraaxial hemorrhages along the bilateral, parietal convexities, along the frontal lobes, possibly some areas of bridging thrombosis or but yeah, focal abnormalities in the extraxial convexities in the bilateral frontal and parietal convexity. On the T1 stage, yeah, in terms of herniations, no mass effects on the posterior structures. Some extraction hemorrhage around the parts, posterior parts out there, which is appreciated on the SWS sequences. Yeah, on these images, that's the main findings I could appreciate. Post contrast, the vessels appear to be accentuated. I think these are probably secondary to the cerebral edema. But in terms of other focal abnormalities, I'm not able to appreciate any significant enhancement. Then 5 days later, anything in between, Basit?
Yeah, sir. This the child was intubated because of his seizures had started after that, but sensorium was not improving, so they had repeated a scan. It was around 1 week after this.
Okay, so 1 week after the presentation, if you look at the SWS sequences, there's some progression in terms of the subdurals going more along the temporal convexities here. You can appreciate the extraxial hemorrhages which are previously seen on the prior study again on the superficial convexities. Yeah, again, frontal, the extends up to the anterior convexity, also the subdural collection. So subdural hemorrhages. So bilateral subdural hemorrhages progress on the follow-up scan. No midline shift or anything or mass effect at this point of time. These are non-contrast T1 sequences on the left. Again, you have some areas of T1 hyperintensities predominantly involving the cortex. And on the post-contrast, we have these areas of enhancement, again, involving the cortical region, some gyral enhancement in the bilateral hemisphere. I think this is a flare contrast, similar pattern on the T1 video sequences. Spectroscopy, what I can appreciate is an elevated choline there, and a lactate out there, and the rest of the peaks are slightly reduced. Yeah, so I think after that, sorry, boss.
So during the course only, the CSF was done initially, that was normal. Protein was 25, sugar 75, and 1 cells. Culture was sterile, and EEG showed generalized background slowing. And his urinary GCMS screening showed increased MMA, suggestive of methylmalonic acidemia, as well as his vitamin B12 levels are very low. That was 98. A CBC consequently showed HB of 7.7, but he had received a blood transfusion. And his coagulum parameters were normal. His ammonia was normal. His echo was normal. But his fundus examination though, that has showed some hemorrhagic lesions, right more than left.
All right. So with that background, I think the big question here is this truly responsible? All changes responsible with MMA or?
Yeah, sir. So initially the child they started on this diet, and it was thought to be a methylmalonic acidemia. But after that, further this investigations, genetics was sent to rule out this methylmalonic acid. That came out to be normal. So in the background of these MRI features, such as some HI features with developing subdural hematomas, as well as this fundus suggestive of hemorrhages. Could it be a non-accidental brain injury? That is the question, because the genetics didn't pick up this methylmalonic acidemia, and his B12 levels were very low. So that was the main question here.
The mother, the child, this was an isolated episode. The child was crying a lot, and then he became lethargic. The exact details are not known, and subsequently he had multiple seizures. He was admitted, and then he had multiple seizures. So it was an acute event, acute afebrile encephalopathy with seizures. And methylmalonic acid, we thought probably because of low vitamin B12, it could be because of that. And so we were strongly thinking of this. The whole thing happened at another hospital. So we just got to see him 2 days back. And we thought it was more like a non-accidental injury. And we just wanted to know whether it fits in.
At presentation now, he is delayed, but he was put on diet already. So genetics had come between negative and some features, MRI features suggest to a non-accidental
injury. Yeah, he is on special diet.
Special diet for MMA.
Yeah, again, please.
Just to confirm, if you have low vitamin B12, you have increased MMA. So I guess you have checked it, or I think you went to genetics. this child has no methylmalonic aciduria, very unlikely. And just a general warning, retinal hemorrhages is not equal to non-accidental injury. I mean, this is quite a strong criticism for the parents, and I think one has to be very careful to exclude other options. If I understood correctly, this child had high blood pressure for a prolonged time. This could be a contributing factor.
Nihaal, I had a question.
Yep.
You think the first CT didn't show the blood because his hemoglobin was very low?
Possibly.
His
You mean in the
hemoglobin was after a transfusion was 7.7.
Yeah. You mean the subdural hematomas?
Yeah. We could not see the subdurals in the blood in the first CT.
Yeah, maybe only over here, these last two panels, if you look at the FARCs, slightly asymmetric out there, but yeah, in terms of, I think these are more, the superficial convex lesions are more clearly picked up actually on the MR than on the CT.
Right.
So the SWIs are very helpful out here. So the typical tadpole sign, if you see the picture of the bridging vein thrombosis. So these are actually more clearly demonstrated on the GRE sequence or SW sequences of the MR than on a CT. Because if, depending on the stage of the hemorrhage, it might be isolated on CT. So that will be a little difficult. I would rely more on the MRI than on the CT. Especially for these convexity hemorrhages, small, tiny ones.
So this child, when he first presented, he was hypotensive and shocked, and then he was on inodrops. And the hypertension was noted later during the hospital admission. And I think the next subsequent MRI is showing the tadpole sign even better, or is just wanted to confirm.
Yeah, you can see them over here. The last two, three sequences. But if we had a look at the first one also, sorry, I didn't put up the zoomed in images. If you see over here, the last panel, one over here in the frontal lobe, these parietal convex lesions. So these are, it's evident on the first MRI also.
So you put,
Was a skeletal survey done by any chance?
No.
And in these cases, as Dr. Magdalena has mentioned previously, also the spine is also very helpful. If you have any spinal intradural hemorrhages, that will be very unlikely for any other possibility rather than any eye. The subdurals and the parenchymal injury can be seen in other mimics, but the spinal hematomas, these are pretty commonly seen or typically seen in NAIs. So I think that skeletal sorry,
yeah. So this has happened almost 2 months back. So I have seen them just now. So doing the we didn't do. And the other thing was this. I think the spine hematoma. If right now also doing the spine would, I don't think, be of any use. So.
But I think any CT was done by any chance? Just to look for any factors. CT brain. I mean. CT head.
CT brain, the first one is a CT, the first scan.
I don't have a bone window for the first scan. If any fractures were detected at that point of
time. I don't think there was a bone window. I'll check that. But what is your first, any other differentials and what could be the possible? And MMA, is it still possible? Though we think that it is because of low vitamin B12 that urine MMA was high.
The typical MMA picture, I mean, what we have commonly seen is usually have more of a deeper nuclear involvement. The peripheral involvement can be variable, but lower spinal involvement, brainstem involvement is more common for MMA. Subdurals and extraction hemorrhages, I think, again, not a very typical presentation for an MMA. It can be secondary to anemia, but the primary changes I don't think can be attributed only to MMA.
Yeah.
Yeah, Dr. Vivek, GPA involvement, MMA, that's not there. Tadpole sign is for bridging vein thrombosis. It looks like because of the shearing injury, the bridging vein becomes thrombosed and it has a head and a tail appearance. I don't have the images, but it's very specific for a non-abusive, for abusive head injury. There was no infection also. Yeah, so
No, CSF was normal.
yeah.
No fever anytime.
What is unusual is the CSF didn't have any RBCs. That was the unusual.
Hmm. Is it a hypoperfusion? Yeah, I think it is. It is.
It's
No?
more of a global hypoxic injury kind of a picture, which can be it can have secondary hypotensive hypoperfusion injuries. But the excessive edema, cytotoxic edema, go with that. Dr. Mankad has just messaged, I think he left, but child needs a skeletal survey favoring abusive trauma. Yeah, I cannot think of any other possibility, alternate possibilities.
Okay.
Reversible vasoconstriction syndrome post-transfusion. It's too diffuse for reversible vasoconstriction. Is usually more posteriorly. This is significant.
Transfusion was given later after the. It was not in the beginning at the presentation. After 2-3 days, the transfusion was given. Yeah. And this is too diffuse for press.
Yeah. And it's too much cytotoxic edema also for press. So I wouldn't go with press. So I think we're leaning with abusive head injury.
Okay. Okay. Thanks.
Okay. I think Shayan message profound hypoxic insult. Yeah, I agree. Hypotension, low ambulance. Okay. There are no. Let's see if anything. Yeah, profound hypoxia looks more like it, but it is also known to be seen in abusive head injury. Strangulation, such things can cause profound hypoxia. So, yeah, thanks, Dr. Kati. Okay. All right, so we'll move on to the next case. Let's see. Shaima says as if there is white cerebellum spine sparing the posterior circulation, but the cerebellum is also involved if you see the first CT itself. You'll see over here the cerebellum is involved. So I think on the MRI also you can appreciate the edematous in the cerebellum. Yeah. All right. Okay, we'll move on to the next case over here. Nilo, just to summarize the thinking, and he has a strong possibility. Mimics, I think, pretty less likely and does not fit into MMA is what we have concluded.
Yeah.
Okay. There are a couple of papers from Bosch Group, and I'll just share it with you. NA and NA mimics, so maybe you can just have a look at it. But yeah, the tadpole size, the extract hemorrhages, diffuse insult favors more of a abuse rating.
Yeah, but this hypoxic ischemic type pattern and fundal hemorrhages, I think, and the tadpole sign.
Yeah. Yeah, metabolic crisis possible, but again, you just put all together, it's into more of a what we're thinking. Okay. Yeah. Thank you. All right, Dr. A, go to you.
So this is a 14-month-old child who I had seen in OPD a month back, and this child actually, even though I have written mild global delay, but he was performing at around 10, 11 months, like a very interactive child, but more of a motor delay rather than cognitive delay. That was not as prominent. My mistake that I wrote it in the history. The day I saw him, I wrote it, and then when I followed him up, I didn't correct it here. The reason they came to me was because he has had 2 episodes of right focal seizures 2 months apart in a febrile illness. And when they came to me, child was well, interactive, no spasticity, tone was normal, no hyperreflexia, no pyramidal signs. And I had done an MRI more for that delay and more for the right focal seizure, with the thought process that in the newborn period, because his weight was 2 kg at birth, that we might have missed hypoglycemic brain injury in the neutral period. So I had to discuss this MRI.
That's a comment. Sorry, Dr. Vivek, I think I missed it all.
So yeah, head size was related. So his head size at 14 months was, because I checked it again after the MRI, was 44 centimeter, which actually for his failure to thrive is higher, is larger. So because his weight is just 7 kg, his height is less. So for a 14-month-old, 44 is 45 at 12, we say. But for this small baby, it would be a larger head.
Got it. All right, with that, we'll have a look at the MR. Yeah, MR, you have confluent changes again demonstrated in the bilateral hemispheres, frontal dominant, predominantly involving the white matter structures, some shading of the cortex out there. Also involving the deep brain nuclear structures, particularly the basal ganglia, more predominantly the anterior aspects, some areas of the central thalamus, and also the brainstem, the midbrain is involved, showing T2 hyperintensities out there. Fornix is also demonstrating T2 hyperintensity, slightly thickened along the lower aspect. There is some hypoplasia of the corpus callosum, and if you look, the head appears slightly, I wouldn't say slightly big, but yeah, it looks a little prominent on the SAT sequences in terms of the front occipital dimensions. Yeah, so predominantly confluent white matter changes with a anterior to posterior gradient involving the basal ganglia structures, involving the fornices, also the mammary bodies and some areas of the midbrain. T1 various sequences, the corresponding T2 sequences demonstrate hypointense changes, hypo to isointense changes. And these are again the flare sequences, again have a similar pattern resembling the T1 sequences. No cysts, no particular large cysts demonstrated in these abnormal white matter structures. Diffusion sequences, I think only the left capsular white matter and the globus striatum and the head of the caudate demonstrated diffusion changes. This did show reversal on the ADC sequences. I don't have them up, but yeah. The other changes demonstrated castrated diffusion, and the SWS sequences do not have any areas of blooming, possibly history of hemorrhage or calcification. With that, based on that, I think the imaging differentials, what we thought of was possibility of leukodystrophies with the anterior to posterior predominance, given that the child was also has a slightly large head, as Dr. Vikas mentioned, for a failure to thrive child. Alexander's disease was the prime consideration. MLCs, we did not have any cysts. Frontal adrenal leukodystrophies, L2 hydroxyglutaric aciduria and Aicardi-Goutieres syndromes are the differentials for leukodystrophies with anterior predominance. Based on the images, I think the first differentials were thought of was Alexander disease, has the white matter involvement, has the fornicer involvement, has the basal ganglia involvement, and also the midbrain brainstem involvement. These are other differentials. Again, it resembles only in terms of pattern, but some imaging differences are there on the other sequences. And L2 hydroxyglutaric aciduria usually has a more subcortical involvement. This has a more diffuse involvement involving the periventricular, deep, and subcortical white matter. We're thinking of Alexander's disease as one of the prime possibilities for this child, and I'll open the case for any further comments and suggestions. And Dr. Vivek, does it match the clinical phenotype? Is the first question.
Yeah, it will match. Did he have brainstem involvement as well?
Yeah. On the T2s, you can see there's some hyperintensity, especially in the periaqueductal region, and also the dorsal brainstem here. Medulla.
Okay, and that is suggestive Alexander. And in L2 hydroxy, you should have cerebellar involvement, right?
Yeah, cerebellar more predominant dentate. For a 14-month-old, this is fine. Up to 2 years, you can have some faint hyperintensities, but should be more dominant out here, and the pattern should be more diffuse rather than in terms of the involvement in the vertically and also transversely. It is more subcortical involvement here. As you can see, it has more periventricular to subcortical diffuse involvement. And fornical involvement again is not common in L2 HGS.
So, right.
I fully support Nihaal's suggestion. Alexander is top on the list. In some patients, when you have given contrast, you see contrast enhancement of the ependuma, like a ventriculitis.
Yeah, the periventricular garland, I think, yeah, I agree. We don't have a contrast, but yeah.
Yes, I
Okay.
agree with you, Dr. Nihaal, as well. It sounds like Alexander disease only.
All right. Cheyenne also agrees. Alexander Canavan as a differential, possibly yes. Again, more diffuse involvement. It has basically involvement, but again, corneal involvement and is not commonly seen in Canavans. And in diffusion, usually it is more significant signal changes in terms of diffusion in Canavans also. So, I would agree Canavans in terms of white matter involvement and basic gang involvement is a differential, but there are some features which are slightly different what we see in Canavans. So, okay, Dr. Vivek, we look forward for the feedback if you have a diagnosis.
So mother is 5 months pregnant, and I did tell them the need for urgent genetic study, but they have decided to think about it before they go ahead. So yeah, they agree.
Okay. Okay.
Well, as you know, Alexander is dominant, usually de novo, but germline mosaicism cannot be excluded. So the recurrence risk is not zero.
And if it
Even
is germline
have
mosaic,
strong
then the
genetic
risk is really high, right? If it is germline mosaic, then the risk is really high.
No one knows actually how much the risk is in germline mosaic, perhaps in the order of 5%.
Right, 5%. Okay.
Okay. That's possible, Alexander. Likely, Alexander. And with that, we'll move on to the next case. Harika, over to you.
Yes. Good evening, sir. This is a 5-year-old male child born to a non-consanguineous couple with normal development. Till Jan 2025 14th, he was normal. Then he had a fever for 2 to 3 days. That was low grade. And interfebrile period, he was active. And 3 days, he was afebrile. Then he developed left upper limb weakness associated with twisting movements. Over the next 3 to 4 days, he developed left lower limb weakness also associated with walking difficulty. And gradually he lost ambulation associated with deviation of mouth to right over these 3 to 4 days while smiling. But his speech was normal, sensorium was normal. He was indicating his needs. On examination, there was left upper limb and lower limb dystonia and also oromandibular dystonia.
Sorry, yeah, go ahead.
In your new onset movement disorder followed preceded by fever, we thought in terms of like demyelination or autoimmune. So we went to imaging.
And not a stroke, right? Given that there's weakness, but any points against a stroke?
No, sir. Like he has walking difficulty, but it's
Okay.
not like a stroke.
Okay. And MRI was done into day of illness. 3
Sir,
days, 4 days after?
they presented after 4 days to our OP. So
Okay.
after 4 days.
Okay, all right. So yeah, we have diffusion ADC sequences and okay, Dr. Tajula, any manifestation, any videos? Sorry, you would have any videos, Dr. Tajula? Yeah, diffusion sequences. There are some areas. I mean, changes are more appreciated on the ADC sequences. We have these areas of confluent abnormalities in the right central semioveil, in the deep brain structures, the internal capsule, the peninsula white matter, also the temporal lobe. Most of them demonstrate facilitated diffusion. Findings are better appreciated on the T2s and the flares. Again, you have the confluent abnormalities more on the right hemisphere, but also involving the left hemisphere. You can appreciate that on the flares on the T2s. You can see over here the left basal ganglia, the caudate nucleus, the putamen is demonstrating hyperintensities. But the main changes, again, on the centrum semioveil, the deep brain nuclear structures, capsular white matter, very subinsular white matter, temporal lobes have these changes. And also the optic chiasm also has these hyperintense matter changes. Some degree of volume loss also in the cerebral parenchyma. As you can see, there's prominence of the sulcal pattern out there. Sorry, I missed out this. There's also some subtle hyperintensities in the posterior cingulate cortex or parietal regions out there, more on the left side. Yeah, I think these are the main findings. on these images. No areas of blooming on the SWA sequences, so no hemorrhage, no calcification, at least appreciated at this point of time. Contrast, there was some patchy enhancement in the basal ganglia abnormalities and also in the middle temporal lobe abnormalities on the right side. No meningeal enhancement seen. No optic nerve enhancement. I don't have the cuts, but yeah, there was no significant enhancement of the optic nerves or the optic pathway structures. Even the chiasm does not demonstrate any enhancement of that. So with that, I think the possibilities was thought of as an immune-mediated or inflammatory immune parainfectious post-infectious disorder related to centered around the basal ganglia. Other possibilities thought was in an infective or inflammatory process secondary to vasculitis. We don't have an MR angiography done, and a very remote possibility of MELAS. I don't think fits into this, but we're thinking more of post-infectious demyelination or something related to infective process related forming of vasculitis like yeah. With that, I think labs were done. Yeah,
Yes. In terms of autoimmune etiology, we are thinking at that time. So we have done CSF analysis, but it was showing 2 cells with protein being 35 and sugars were 62. And serum autoimmune antibodies were negative. And ESR was normal. Serum NMO-MOG antibodies were sent. MOG was mild positive. Child was given 5 days of IV methylprednisolone, but still no improvement. And then child was started on rituximab. Recently, we have given second dose of rituximab, but still no much improvement in his dystonias.
So what is the question here, Harika? Any specific?
So our question is whether like it is really like demyelination because there is no improvement with immunotherapy.
Okay.
So,
all right, hello.
Yeah, sorry.
Yeah, okay. Sorry, go ahead.
So, MELAS or a metabolic disorder is unlikely because diffusion restriction is not significant. But when one sees the contrast enhancement, it has that radial pattern of GFAP antibodies.
Yeah, that was raised. I think it was not tested though, if I'm not mistaken.
So, yeah. So one. Second is HLH. I've seen 2 patients who have presented like this. And third is SSP. So we should do a EG in this child.
Okay, sir.
How long since immunotherapy, Dr. Tajulas? How long since immunotherapy?
Sir, like 1.5 months, child is on immunotherapy. They presented in January. So we started on IV methylprednisolone and then oral steroids maintenance and then rituximab also.
And is OTPT normal? Ceruloplasmin normal?
Ceruloplasmin, we have not done, so we'll get it.
Just in case, because 5-year-old and like it doesn't classically fit, but liver function test, if it's normal, it's unlikely. Less likely.
Tests were normal, sir.
Can I just add, as a reminder, neurological manifestation in Wilson disease is not possible before 9 or 10 years. It is possible in terms of hemolytic anemia or liver involvement, but not a neurological involvement at 5 years.
All right, thanks again. Question from David, does it fit the MOGAT criteria in context of low MOG titers? Is the blood sugar also normal, HbA1c from Hina? Harika, you want to take that up?
HbA1c? No, sir, we haven't done HbA1c.
Any reason for HbA1c? I mean, the blood sugar, Hina?
We have done blood sugar like before doing this LP, it was normal.
Yeah, I'm just asking her reasoning. Yes. Unilateral steatopathy in diabetes, but these are bilateral lesions, so they're predominantly right side, but as you have seen, they are on both sides. Okay. Yeah, so I think as Dr. Vivek has mentioned, GFAP, if it's not been tested, to be tested, and an EEG, yeah, NHLH.
Sure, sir.
Okay.
Yes.
And then we need to do a follow-up scan When was this done? Sorry. January. I think is 3 months okay, Dr. Vivek, or one?
Was that, sorry?
A follow-up? Do we need to get a follow-up, like just
I
to see
don't
is it
think
that
unless the child
okay.
improves,
Improves?
it
Okay.
won't help. Even if it is, a child should show improvement. Then
Got it.
only the only
No,
problem is
I'm
now the
seeing.
CSF
I'm
is
thinking if
already
there's
been done.
any
Mhm.
progression in terms of imaging.
Progression. Okay. Yeah, that
For
will
that.
help because CSF you cannot repeat now. Even if the EG shows periodic complexes, if it does, family will not agree. So maybe at 3 months, just to, if they stay with you, so to convince if to do a CSF again.
Sure, sir.
Okay, so yeah, Harika, let us know. SWA sequence for HLH, SWA did not demonstrate any hemorrhages at this point of time. Possible. Anyone, any possibility of a diffuse glioma or astrocytoma? If anyone thinks that's a possibility. Oh yeah, Dr. Nihaal also mentions that. Yeah, that's why I thought we need to get a follow-up scan just to see if there's any progression.
Sure, sir. We'll ask them for follow-up. We'll get it done.
And I think we just need to do a basic spectroscopy follow-up and see if there's any mass effect and progression in terms of things.
Sure.
Okay. Venous infarct, Dr. Sharma, but diffusion it does not show any, though you'd expect some areas of diffusion restriction. And it's more slightly likely bilateral. Yeah. Okay. So, Arika, I think test for G5 versus HLH and a follow-up scan a 3-month interval should suffice for now.
Yes, sir. Okay, sir.
Yeah. Okay. How do you next case?
This is another child. He's 5 years old male child. They presented with complaints of tilting of head to one side for last 6 months. He's tilting his head to left side occasionally, but it is occurring like almost many times throughout the day, and no difficulty in looking at different distant objects, and it is associated with walking difficulty. That there is a difficulty. There is difficulty in flexing his ankle while walking, and this difficulty in walking is non-progressive. And he also complains of pain while walking longer distances, which was mild in severity and decreases with rest. And this walking difficulty sometimes also with falls. And there is also difficulty in running and jumping and climbing up and down stairs that he is requiring support. On examination, head circumference was 55 centimeters, and there are multiple KFLI spots all over the body. Normal dermatoglyphics, bilateral proptosis is there, but extraocular movements are full. There is gaze evoked nystagmus, no facial or bulbar weakness. Tone was normal. There is right tendinoculus contracture. DTRs are brisk with power being normal in both upper limb and lower limb. Tandem walking is normal, but there is past pointing and dysdiadokinesia. And there is difficulty in jumping, that he's jumping only like with very mild. He has difficulty while jumping.
All right. Any clinical diagnosis possibilities?
Sir, apart from this head tilt is also like so mild.
Okay.
Only while walking, he's putting this head tilt to other side. And he was in normal development till then.
All right. Yeah, I have just images from the films, slightly pixelated. So apologies for the quality of images. As you can appreciate, there is hydrocephalus, significant dilatation of the lateral ventricles, third ventricles, rounding of the temporal horns, periventricular edema out there. Some areas of T2 hyperintensities, the bilateral proboscidali, also in the cerebellum, and some patchy areas involving the brainstem structures. See, yeah, on the diffusion sequences, I don't have an ADC to correlate the slightly hyperintense signal changes on the DWIs, but you can appreciate slightly hyperintense changes on the lowest value, maybe T2 shine through or real diffusion, but I don't have the ADCs. And on the flares, again, you have better appreciate the hyperintense abnormalities, focal lesions in the lowest value, the posterior photostructures, that is the brainstem, and also more significantly or prominently in the cerebellum, with the significant dilatation of the lateral and the ventricles. The post ventricle is compressed, I think better appreciated on the SAD sequences. All right, very difficult to look at the aqueduct out here, but it appears to be narrow with some altered signal changes in the periaqueductal region. The port contrast